All right, Larry, you win the tip of the day award of having the scope into the ilium for a good distance before you put the stapler on, because I think that's something which is not always easy to assess. I'm going to move on to my talk at this point, and we're going to talk about doing something which I think is exceedingly difficult. If you think the laparoscopy is hard and you think that SILS is hard, trying to take out a polyp completely using a knife blade is exceedingly difficult. So if we can load up Marcello Lap ESD. First of all, let me ask in the audience, who has availability of doing endoscopy in the OR? Put your hand up if you can do a colonoscopy in the OR. Good. How many of you, however, have the ability to use CO2 endoscopy in the OR? All right. I would tell you that the most critical thing in your future is buying that CO2 insufflator. I think it makes the procedures go so much easier. And whether I'm doing a hemorrhoidectomy or a major resection, I'm very easy to doing CO2 endoscopy. It also gets your nursing staff used to having scopes in the OR. And then, as Larry said, when it comes to bringing forth doing polypectomies through an endoscope, I had to train my nurses, basically. And so I couldn't count on getting a nurse from the endoscopy unit downstairs, so we're lucky to have dedicated colorectal nurses. I've just trained them all how to use it. And actually, for the most part, I have my resident or fellow with me. They assist me with the polypectomy part of the operation. So I'm going to try to bring forth ESD. These are my disclosures in terms of the companies that I consult with. And I have worked with Olympus to help improve products and bring it forth to us. This is what we're talking about. This is what the gastroenterologist sends you pictures of what you need to remove. And we've talked about a variety of options. And I think my goal has been to try to remove these in one complete piece to allow the best pathological evaluation, and we'll talk about that. The ESD has been, you read about it in the Sages and your other journals, it's really been heralded by the Japanese and applied mainly to the stomach. And they had, for a decade or more now, an extensive training program that they put their doctors through. And then once you've mastered the stomach, you attempt the colon. I had the fortune of, with Matt Much and Mark Singer, to go and meet Dr. Yahagi, who's one of the premier endoscopic surgeons, is how I'll put it. He's a gastroenterologist. But when I asked Dr. Yahagi, how do we do this? He goes, well, do 100 or 200 gastric cases and then try the colon. I'm like, well, okay, that'll take my whole career before I can even start. Because it's not practical, because we don't see gastric lesions that we're going to have access to. So we've had to sort of rethink how we're going to do this and how we can do this safely in our practice. This is a gastroenterologist, Maynard Antillen, who's now at Oxford Clinic. This was done by ESD in the colon. I won't tell you how long it took, a long while, but this is what can be achieved to be removed through an endoscope. This will come out small, but I'll raise the important points. There are a number of articles that have compared doing an EMR, which is basically a piecemeal polypectomy with saline, or ESD. This is one of the Japanese articles. They had 145 ESDs compared to 228 EMRs. The en bloc resection, how often did you get the whole polyp out in one piece? 84% with ESD versus only 33%. Recurrence rates. For ESD, it was 2% versus 14%, and we think we've seen many of the times that you do a piecemeal excision, you go back later, there's still something left, and that's less likely to happen if you get it all out in one piece. So I think that's the goal that we're all trying to achieve. But the perforation rate, this is, again, one of the most experienced groups in Japan reporting the results. They still have a 6% perforation rate compared to 1.3% for EMR. And that's really the problem that we deal with. So how do we manage polyps and introduce ESD safely into the United States, and how do we handle the high perforation rate? And so this has been something which, as a new technology and at Sages, we're trying together to try to develop a program that will allow this to be brought to you and for you to bring it to your patients safely. And first, you have to have the equipment, you have to have a desire, So you need to be an experienced laparoscopist. How many of you can suture laparoscopically well? Okay. If I go to my partners, a lot of them can do a lap colectomy, but when it comes to actually suturing, they're a little bit, they're not as good or as comfortable. And here, I think if you're going to do this technique, you've got to be exceedingly comfortable with suturing as a mainstay of it. And if you don't know how to do it, then I recommend you practice because you're going to need to oversew things when you do these procedures. And you also need to be a very experienced endoscopist. I think, though, that surgeons are uniquely qualified, though, to do this. An endoscopist isn't going to try to take out a large polyp by ESD. But I think we're sent these patients, we should be trying to do what's best for them. You do need the availability of have access for rectal lesions, some alternative method, either a TAMIS or a TEMS. You need to have CO2, you need an irrigating system and a desire. So we're trying to figure out now, how can we assess in a training program the proficiency that's required? And we're working through the modules now of what it would take. And something as simple as on a piece of paper, make a figure of 8 using an endoscope with a marker on the tip. It is exceedingly difficult. And if you remember the Olympics in ice skating, they had the compulsories where the skaters had to go around and do the circles. That went away. Well, I think we're going to bring it back if we're going to actually do this technique because we're not used to curving and bending the scopes in a motion. And if you're going to do ESD, you need to do that, and I'll show you that in the videos. You also need a backup plan because if you try to take out a rectal polyp and you can't do it by ESD, you need to have an alternative, and that's usually a TEMS or a TAMIS or some transanal approach. And for the colon, we've got a variety of different options which you've heard about. You need the right equipment, probably a double channel scope. You need the right instruments, and when we start doing this, we need to be willing to share our data. Let's see, guys, can you make my video run? Because it ran before. I won't touch it. So somebody down back, please make my video run. So we start the technique just like you would a transanal excision. You're going to see the lesion. We're going to raise it up with some saline. The problem Larry talked about is that the saline doesn't allow it to lift for a long period of time. So you start raising it up, and 5 minutes later, the saline is gone. The Japanese will often combine products in their solutions, like glycerol or other agents. Hyaluronic acid has been utilized, high concentration dextrose to keep the lift there. If this isn't shown in a minute, what I'll do is I'll move on to Dr. Stamos' talk, so Mikey may be up, and I'll come back and load up personally my videos, because I think people want to see what we're actually doing. The hardest problem I have is that the lift doesn't last. Sang, are you using any solutions or anything else to make it the lift last longer, or just saline?
Saline, but there's an ophthalmologic solution called Gonac, which is like the artificial tear, which
all right,
some
Gonac.
people use. Yeah.
So Gonac, and I think it contains...
it's like a methylcellulose artificial tear, which
right.
tends to last a lot longer.
Okay, so we have other products that we can utilize. Larry, what are you using?
We just use saline with epi, and it's not adequate.
All right, so Gonac, off-label use of a product, but if you can get it into your hospital, that might be a benefit. Guys back there, do we want me to come back and load up my videos? Good.